Imagine this, a client at 12 weeks gestation comes in excited for her first ultrasound, but she has some light bleeding and cramping. What's running through your mind as the nurse? You got it. We're thinking threatened abortion. I'm Miriam, and we're going to unpack three big NCLEX topics: spontaneous abortion, cervical insufficiency, and intrauterine fetal demise. These may not be high drama NCLEX scenarios, but they're still really important. So let's talk about what to do when pregnancy doesn't go as planned. And let's start with what happens before 20 weeks gestation. A spontaneous abortion or miscarriage is a pregnancy that ends before 20 weeks and before fetal viability. That means that fetus cannot survive on its own on the outside. Now, the number one culprit or risk factor are going to be fetal chromosomal abnormalities. This is like genetic defects, things that are not compatible with life. Other risk factors, think maternal endocrine disorders like hypothyroidism, uncontrolled diabetes, obesity, and then we also have advanced maternal age over 35 and substance abuse disorders. But how do we tell which type of abortion we're dealing with? Well, the type will depend on if there's cervical dilation and if there's been tissue passage or not. Threatened means that the pregnancy is still holding on. We have some spotting, but no tissue has passed. Missed miscarriage means that the pregnancy has ended, but the tissue is still inside. The body literally missed the fact that a miscarriage happened. Inevitable means that cervix is dilating and the loss cannot be stopped. Incomplete, we have some tissue out, but some remains, and we can have heavy bleeding here as that body tries to expel that remaining tissue. Complete, that means everything has passed, and that bleeding is going to transition from heavy to light as that cervix closes back up. So you have a client come in that has heavy bleeding. What will you do? Well, we need to assess blood loss and for fetal viability. So first, assessing that blood loss. Now, to assess blood loss, we're going to watch for pad counts, ask the client if they pass any clots, and see if they have any passage of tissue. And of course, we'll be checking for any foul odor that could mean we have an infection from that retained tissue. And we'll monitor for hemorrhage, so things like increased heart rate, decreased blood pressure, and of course those labs for a low H&H. Next, we need to confirm that fetal viability. So all early pregnancy bleeding or cramping should be treated like a threatened abortion until we've determined if there's any fetal cardiac activity, meaning it's viable, or that there's been pregnancy loss and it's non-viable. So we'll do this with ultrasounds to check if there's any fetal tissue, if there's cardiac activity, and we'll also be watching serial beta-hCG levels, and that's going to tell us if that pregnancy is growing or not. So increasing beta-hCG levels means that that fetus is growing and that pregnancy is viable. Decreasing beta-hCG levels means that it's a non-viable pregnancy. Now, if pregnancy is viable, we can discharge the client home with follow-up for repeat beta-hCG levels and ultrasounds to monitor growth. But what if the pregnancy is not viable? So we'll administer uterine stimulants like misoprostol and oxytocin to promote tissue expulsion. Now, if those meds are ineffective or there's complications like heavy bleeding or infection, then we need to have surgical removal, like with a DNC. Now, after the DNC, we want to administer oxytocin or methyl-ergonovine to contract that uterus and prevent hemorrhage. And don't forget, if that mom is Rh negative, we have to give Rh immunoglobulin, since we don't know what that baby's blood type was, and we have to prevent sensitization from fetal maternal blood mixture that might have happened. And remember that can cause Rh isoimmunization in future pregnancies. Okay, so after that tissue is gone, our focus is going to shift to healing and prevention. So our teaching is going to focus on infection prevention and recovery. So we're going to teach clients to follow pelvic rest. So no tampons and no intercourse until that bleeding stops. We also want them to call the provider if they have any signs of infection, and that would be things like abdominal tenderness or any foul-odored vaginal discharge. And for recovery, we want them to eat iron-rich foods like spinach, lentils, and tofu to help them replace that lost blood volume. Emotional recovery is going to be really important too, so we want to encourage them to attend support groups and allow themselves time to grieve before they try to conceive again. All right, time for your first NCLEX quick check, so pause and try to answer. Miscarriage occurs when pregnancy spontaneously ends at how many weeks gestation? Remember, miscarriage occurs when pregnancy spontaneously ends less than 20 weeks gestation, and this is often from chromosomal abnormalities. How should you assess blood loss, and what interventions should you perform for retained tissue? We're going to assess blood loss by doing pad counts and monitoring for hemorrhage, things like decreased blood pressure and increased heart rate. We'll also administer uterine stimulants to help remove that tissue and prepare the client for a DNC if it's unsuccessful. How do clients perform pelvic rest? Well, remember, we want to teach them no tampons and no intercourse until bleeding stops. Now let's move to something a little quieter, painless in fact. This is incompetent cervix or cervical insufficiency. And this is where we have painless cervical dilation where that cervix opens way too early. This is going to lead to preterm birth or losses that are usually in the second trimester. Common causes or risks, that's going to be anything that would weaken the cervix. So previous cervical surgery like conization, or maybe they were born and have a congenital weakness to their cervix. Now, how will you know if your client is experiencing this? Well, unfortunately, we find out when it's way too late usually. The client will have cervical shortening or thinning and dilation without pain, and this is usually confirmed by cervical exams or ultrasound, usually incidentally when scans are being done or an assessment when a client reports increased vaginal discharge or pelvic pressure. This is the worst because we can't really do anything at this point, and our focus is going to shift to prevention in future pregnancies. So what's our key intervention? Well, we want to prevent cervical changes in future pregnancies. So to do this, we'll prepare the client for a cervical cerclage if they're less than 23 weeks gestation. This stitch will help keep that cervix closed until the client is 36 weeks or if labor begins. On the NCLEX, when you see anything about an incompetent cervix, I want you to remember a cerclage until 36 weeks or when labor starts. And we might also give the client progesterone to reduce the risk of preterm changes, and clients might be advised to avoid sexual intercourse. Now, our education after they have had a cerclage placed is to teach clients to report any signs of infection, fever, foul-smelling discharge, or if they have signs of labor, like contractions under 5 minutes apart or ruptured membranes. Time for our next quick check, so pause and try to answer. Is cervical insufficiency characterized by painless or painful cervical dilation? Remember, it's painless, and that's the problem. We don't see this coming on, and it often leads to these second trimester miscarriages or severely preterm birth. To keep the cervix closed, clients should receive what? Remember, we're going to prepare that client for a cerclage placement if they're less than 23 weeks, and that's going to keep that cervix closed until 36 weeks or labor starts. All right, we've talked early and middle pregnancy losses, but what if pregnancy reaches near term and tragedy strikes? Well, that's an intrauterine fetal demise or an IUFD. This is a fetal death at or after 20 weeks gestation, and causes are going to range from maternal, like poorly controlled diabetes, or fetal chromosomal abnormalities, or it could be a placental problem like placental abruption, umbilical cord knots, or an intrauterine infection. Our nursing role, compassion first and task second. We will definitely prepare this client for delivery, but more importantly, we have to support grief, and we'll do this with therapeutic communication. We can do things like ask the baby's name. Referring to that baby by name can be comforting. We can ask if the client wants to hold the baby to help cope, but never force this. And we want to ask the client about any spiritual or cultural practices to help meet the client needs. And of course, we want to show empathy to allow the client to discuss feelings. So saying things like, I'm sorry, this must be so difficult. And we want to avoid minimizing feelings like it was meant to be, or at least you have another child. And remember this star point. It is really important for these clients to help create a keepsake. So things like footprints, photos, a blanket, lock of hair, all put together in a box. We also want to refer these clients to support groups and teach them to watch for signs of postpartum depression, like depressed mood lasting over 2 weeks. All right, let's pull it all together. So a spontaneous abortion is a loss less than 20 weeks gestation with possible vaginal bleeding and tissue loss. And we're going to manage blood loss here, help remove any retained tissue, and teach the client about infection prevention. In cervical insufficiency, this is painless dilation. And remember, there isn't much we can do for the current pregnancy. So in future pregnancies, we'll prep for cerclage placement and teach the client to monitor for signs of infection or labor. In intrauterine fetal demise, this is a loss at or after 20 weeks gestation. And here we're going to prioritize empathy, support, and follow-up care. All right, you're ready for abortion, cervical insufficiency, and intrauterine fetal demise on the NCLEX.